Welcome to this 14Fish Library module on post-traumatic stress disorder. It's come from a number of different sources, but in particular from NICE Clinical Guidance 26, which was updated last year. I wanted to cover this important topic for lots of different reasons. I work in an area which got a large number of ex-servicemen and women, and so we do see the variable presentations of PTSD in the surgery reasonably regularly. And I also wanted to talk a bit about it because 20 years ago I was a soldier myself, and I think it's fair to say that on one of my tours with an infantry unit in the former Yugoslavia, a number of us were exposed to quite traumatic incidents. And as a result, I think it's fair to say that I had PTSD over a period of time. It's taken me a long time to consider a diagnosis of PTSD, let alone to admit it, as if in some sort of way it made us less deserved of some of the awards and things that we got while we were on the tour. And equally, from a confidence point of view, and I think, do people consider you less of a man if you've had PTSD? And I hope over the 20 years that people are more able to talk about their feelings and their emotions. However, it is a fact that in the United States, that over 20 US servicemen commit suicide every day. And that's because of PTSD. And there must be a similar sort of number. Obviously, we have less servicemen, but there will be a similar proportion of British servicemen and women who will be doing the same. And so I think it's important that we're thinking about this much more than we do at the moment. Many of you will have heard about Mission 22, which aims to raise awareness on post-traumatic stress disorder. And so a number of us have been doing 22 press-ups for 22 consecutive days and making donations to organisations like Combat Stress to support some of our ex-servicemen. I've been doing Mission 22, the Mission 22 challenge, and I've included a short video of my rather feeble attempt at the end of this film. Hopefully some of you will join in and join me and get involved as well. The key to PTSD for us as family doctors is having an awareness of how common it is and actually thinking about it on a daily basis. Without thinking about it, you're not going to make the diagnosis. We need to be actively looking for the symptoms and having a good working knowledge of the options for management and what support there is available in your local communities. PTSD is alive and well in all of our communities, and we need to track it down and do much more to minimise the devastating effects. So what is stress? In its true form, it's a mismatch between the abnormal demands on an individual and their ability to cope. Because we hear it all the time, don't we? We hear even children now saying, oh, they've been a bit stressed. And dealing with these external factors is almost certainly down to resilience, and resilience to stressful events varies hugely amongst the population. We all have some sort of stress in our daily lives, and it's important not to medicalise reactions to stressful events. So post-traumatic stress disorder is of a different magnitude, and it develops in response to stresses that are severe and abnormal in nature, and often those stresses are life-threatening. So PTSD doesn't develop following traumatic events such as bereavement or divorce or loss of a job or failing an exam. It is of a different magnitude, and we do need to try and separate the two. PTSD was first recognised in the First World War, and it was originally the term of shell shock or battle shock, and it was thought to be as a response for prolonged exposure to intensive bombardment by artillery, and that did include gas attacks. Many soldiers of both sides in the First World War were discharged to a pitiful existence for the rest of their lives with severe psychiatric problems, and even in the extreme, because there was no recognition of the negative effect on people's psyche, that it was poorly managed, and in some instance afflicted soldiers were executed as deserters. The original diagnosis of PTSD, or the ability to diagnose it, was described in DSM-3, which is an American diagnostic criteria for mental health, and that was in the 1980s, and it was first termed after the Vietnam War. But it's probably important. I know that I'm going to be, from my own experiences and from the patients that I look after, I'm going to be talking quite a lot about servicemen. However, it's really important to remember that PTSD isn't just confined to soldiers. It can be precipitated often by life-threatening other events, including child abuse, sexual assault, domestic abuse, road traffic accidents, that sort of thing. Through a lot of the modules, we've tried to work out the risk factors. So what is it that puts people at more risk? So when you see somebody from a particular demographic come into your surgery, what risk factors are there as a civilian and as a soldier that makes you more likely to get a diagnosis of PTSD? And refugees and asylum seekers are right up there. And throughout Europe, we're going to see more and more of this, and we're going to see more patients. You may be in an area in UK in which you have a number of rehoused refugees and asylum seekers, and it's definitely worth thinking about that. First responders, so ambulancemen, policemen, fire crews are much more likely to get PTSD, and that's because they have a high exposure to traumatic events. And some of them, there's no doubt, are much more resilient just by the very nature of their personality. However, you should be thinking about that, thinking about the people who are there, who not just exposed because they were the victims, but also because they were the people who went in to help. There is a huge cultural difference on how people respond to stress. And I think in one of the incidents that I was involved in just after the first Gulf War, a couple of teenage Kuwaiti children were wandered into a minefield, and both of them had traumatic limb amputations, so were lying in the minefield having lost legs. And by the time we got to them, they were sat very, very quietly, letting themselves bleed out, and all they were saying very quietly under their breaths was "Inshallah," which means "if God wills it." And certainly I'm sure that a Western child who had lost a leg like that wouldn't be quite so accepting of the circumstance. So think about the presentation, and culturally there may be a significant difference. Anyone who's had PTSD before is more likely to get PTSD again. Anyone with any previous psychiatric disorder is more at risk of PTSD. Women are twice as likely to get PTSD as men. People with a background of chronic disease or chronic pain, once again. And postnatally, we don't really think about postnatally people getting PTSD, but while I was preparing for this module, I saw somebody in postnatal clinic the other day, and she's a very fit young woman who for the first time in her life went into hospital and had drips in, and then had an emergency cesarean section. And she actually said to me, I think for a period of a few weeks after the labour, I think I did have PTSD. And we were able to talk about it because I said, you know, this is one of the biggest risk factors. And there's no doubt that the health and safety culture, so the modern approach to risk management, which attempts to reduce exposure, may actually increase risk aversion, reduce resilience, and make us more likely to get PTSD. In soldiers particularly, in servicemen particularly, there are a number of risk factors, including duration of combat exposure. So the longer the period of exposure to these traumatic events, the more likely you are to get PTSD. Low morale in soldiers, so somebody who's been to a war where they felt unsupported or unhelped. Lower rank, so your junior soldiers. Soldiers that are single, soldiers that have poor social support, so when they go home they don't have the ability to talk to somebody, they don't feel supportive and loved when they get back. Soldiers who've had childhood adversity, and that may account for quite a large number, and soldiers with low educational achievement. Where can we help in primary care? Well, we need to start thinking about recognition, because the recognition of PTSD is often poor. And it often presents, so 85% of people with PTSD present at a later date in relationship to the incident, and therefore it's not quite so easy to make the connection. So they don't immediately come in and say, I was in a road traffic accident yesterday. So they often present with other things, so depression, in particular drug and alcohol misuse, anger, people with a very short fuse, loss, relationship issues, unable to maintain relationships for any period of time, and patients that come to the surgery a lot. And we talked in the multiple unexplained symptomatology module about the reasons for that, and one of them is definitely PTSD. And so if you're seeing these patients, a sensitive inquiry into past traumatic and childhood experiences is definitely worthwhile. And in fact, probably going a bit further, and those people who are high risk, so who've been involved in an incident, it's worth screening for them. And so how can we screen? There's the PTSD, which is a primary care PTSD screening tool, which was reviewed in a systemic review in 2013. And that seems to be highly effective and certainly worthwhile in the first instance if you're suspicious. And so the question is, if you ask 4 questions, and if the answer is yes to 3 or more of the questions, that should warrant further investigation and questioning. And so in your life, have you ever had any experience that was so frightening, horrible, upsetting, that in the last month you've had unwanted thoughts or nightmares about the event, avoided situations that reminded you of the event? Do you feel on guard, watchful and easily startled? And do you feel numb or detached from others? And as I say, an answer yes to 3 or more of those questions would result in you wanting to investigate further. And if you don't feel skilled enough to do that, you might want to refer them to one of the organisations that will help, for example, in soldiers like Combat Stress. Throughout the NICE guidance, they make it very clear to think about suicidal risk and assessing suicidal risk. And we've talked about that in the depression module, so I'm not going to cover it here. But thinking about suicide risk, because these are young people, particularly young men, and young men generally do things violently and will often kill themselves. It's not a cry for help. So suicide risk is really, really important. So the main symptoms, there are 3 sort of categories. There's the re-experiencing, there's the avoidance or rumination, and there's hyperarousal. And let's chat a little bit more about those groups themselves. So re-experiencing, these are your classic sort of flashbacks, as if the event was happening again. Nightmares, this is something that I found particularly invasive. They were common and repetitive nightmares, and they were often of situations that had actually gone very well in the situation that I was in. But then in the nightmares, then actually they all went horribly wrong, and people who weren't really injured did get injured. Distressing images or other sensory impressions from the event intrude during your waking day, and reminders of the traumatic event can provoke quite significant distress. And that reminder can be situations, smells, people, all sorts of triggers. So the avoidance or rumination is avoiding, so actively avoiding reminders of the trauma. Once again, that can be people, situations or circumstances. Suppressing memories and avoid thinking about the worst aspects of that trauma. Ruminating excessively and preventing themselves from coming to terms with the experience. Quite often you hear ex-servicemen and people who've been traumatized sort of saying, why did it happen to them? And if they had not got on that train, they would have avoided it. Who is to blame, and how can they take revenge, and how can they sort of get even with it? Hyperarousal, once again, very common feature. Hyperarousal, or the opposite of hyperarousal, which is emotional numbing. So hyperarousal is a hypervigilance, an exaggerated startle response. Somebody slams a door or drops something, and the person is very, very agitated, or they feel quite scared. Irritability and difficulty concentrating, sleep disturbance and sleep problems, difficulty experiencing emotions, feelings of detachment from others and relationship issues, giving up previously significant, important activities, particularly leisure activities, and amnesia of the main aspects of the trauma. There isn't a huge amount of evidence to do with PTSD, but there's been an awful lot written about it. So why does it happen? Well, we don't really know, but the theory is that our stress response system is the hypothalamus pituitary axis in the brain. And a bit like a thermostat, the thermostat stimulates other organs to release chemicals which then give you a stress response. So your fight and flight. So we're specifically talking about adrenaline, noradrenaline, and we're specifically talking about ACTH, which stimulates the adrenal glands to release cortisol. And we're also talking a little bit about the crossover with the thyroid and producing more thyroxine. And so all of those chemicals then stimulate the fight or flight response, which then, as those chemicals go back to the hypothalamus pituitary axis, it should switch it off. So a bit like your radiator system, when the house starts to heat up, the thermostat should turn off. But for some reason in PTSD, whether it's prolonged exposure or the severity of the exposure, the hypothalamus pituitary axis becomes deregulated. It almost sort of breaks. So there's no feedback mechanism. So these chemicals are produced in massive amounts, which then results in these particularly invasive, particularly difficult memories to deal with, and they're not filed away in the proper way. And so the theory is that it's almost like traumatic brain injury, and in fact that there is a neurobiological temporary or otherwise damage to the system that should be protecting us. So where are we with the management of PTSD? And although there is limited evidence as to what is effective, then NICE has reviewed all of the evidence and gives us what is it that we should be doing to people with PTSD, or where should we be sending them? And certainly when I left the military, single session intervention, which was often referred to as debriefing, is now thought to be at best ineffective, and at worst it may well be harmful for the treatment of PTSD. A large number of people exposed to a traumatic event will have some symptoms of PTSD within the first month. And unless those symptoms are particularly invasive and actually invading function, so stopping people doing their day-to-day life, stopping them going to work, stopping them functioning at home, then watchful waiting is probably the most appropriate. You would only intervene in the first month with very invasive symptoms. But then after a month, trauma-focused CBT is first line, and that will have to be delivered by people who are trained appropriately in it. And treating, we've talked about other comorbid states and depression and so on. Treat PTSD first rather than thinking about treating anxiety and depression. And you would only treat the other comorbid illnesses if they're going to interfere with your treatment. So for example, in someone who's drinking extremely heavily, you would need to treat that, particularly if you were then going to go on to give them medication. And we'll talk a little bit about SSRIs and alcohol in a second. So EMDR, eye movement desensitization and reprocessing, it's been around about for 20 years. It's only really come into the main arena 2 years ago, but there's a massive amount of evidence that this is an effective treatment for PTSD, particularly when there's invasive thoughts and invasive nightmares. And I'm going to talk a little bit about that in a minute. Stress management, but focusing on the trauma. And avoiding non-trauma focused interventions is where we are. So what is EMDR? It helps the brain process traumatic events. It reduces distress in the shortest time, but it has to be delivered by people trained in this technique. It's a one-to-one thing. They're usually given 8 to 12 sessions, and each session lasts about 90 minutes. And distressing images are recalled whilst you get the patient to flick their eyes backwards and forwards. I've read a lot about this and I've been quite impressed. It does sound bonkers when you first hear about it, but I've read quite a lot about it, and the theory is that, as with all filing systems in our brain, sometimes we end up having a series of things that we've left behind, like a sort of, your desk at work when it's covered in stuff. And for some reason, we haven't gone into filing those and getting to deal with those memories. It's not talking about deleting the memories. It's talking about making those memories acceptable. And the evidence would suggest, if you look at our sleep cycle, so we have a 90-minute sleep cycle with various depths of sleep. So you go from phase 1, 2, 3 and into 4. 4 is very similar to a general anesthetic, and if you try and wake somebody out of 4, it really is quite difficult. And then they pop up into a semi-conscious state, which is the rapid eye movement sleep. And if you watch somebody in rapid eye movement, you'll see that their eyes are flicking from one side to another. And so the theory is, and it seems to have been brought out in a number of the trials, is that you can actually, when somebody is conscious, get them to flick their eyes from one side to another while they are discussing and thinking about invasive memories and invasive incidents that have happened, and that somehow gets them able then to file it away and to put it somewhere where they can deal with it, as opposed to it just being in there and invading in somebody's life. So what about drug treatment? Drug treatment is definitely second line. The SSRIs are the main line of treatment. Paroxetine has got the best evidence for it. NICE also recommend metrazapine, and in the guidance they talk quite clearly about if hypnotics, you know, your temazepams, diazepam, if hypnotics are used for insomnia, that they shouldn't be used for more than a month. And if you are finding that someone is needing something to help with sleep, then they should be replaced with antidepressants. I talked about the hypothalamus pituitary axis, and I talked about this sort of thermostat regulation. And so it's quite interesting to look at what may be in the future. And so, you know, all of this fight and flight is adrenaline and noradrenaline based. And so there is some evidence for the use of beta blockers. There is some evidence for use of alpha blockers like clonidine. There's also some evidence about stellate ganglion block. For those of you who can't remember from your anatomy, the stellate ganglion is the sympathetic nervous system that is in the neck. And injecting that with anesthetic in some people seems to work. And once again, we mentioned the thermostat regulation, and there is a little bit of evidence to suggest that if very soon after a traumatic event someone has some intravenous cortisol, that cortisol switches the hypothalamus pituitary axis off before it gets damaged. And so, you know, there's going to be future developments and more research, but don't forget, you know, go to somebody. If you've got somebody you're suspicious of post-traumatic stress disorder, you know, refer them on to an agency that have got trained therapists that can deal with it. And you should get involved in conjunction with those therapists and get to know what they're doing and at what point you need to start adding in medication. So the prognosis, by and large, is very good. About 80 to 90% of people spontaneously recover. And we've talked about the risk factors for PTSD and why they might not recover and why they might need support. Not to forget that symptoms may occur many years after the event, and that then makes the association with the event quite difficult. And with no treatments, some people will still have symptoms 10, 20 years later. And it doesn't matter when you start treatment because it's still effective. So don't think you've missed the boat. I had somebody who was on D+1 the other day, a patient in their 80s who was on the first day of Dunkirk, and they've still got symptoms of PTSD, and we're going to look at actively treating them. Initial severity is quite a good indicator of prognosis. So if someone has severe symptoms within the first 4 to 6 weeks, that's a bad prognostic indicator. And there's no doubt that people pursuing claims for compensation after PTSD definitely reduce and slow recovery rates. There's a couple of useful websites for you. That's the Royal College of Psychiatry, which provides lots of useful leaflets and help. That's Combat Stress, which deal with all ex-servicemen and territorial reserve groups of servicemen, and definitely worth plugging into them as early as possible. And I think this is a nice comment, really. We need to respect and reward courage and resilience, but not to stigmatize the opposite. You know, look after these people. It doesn't mean that there's something wrong with them. It doesn't mean that they're spineless. It doesn't mean that they lack courage or bravery. But actually what they do need is our help, because there is almost certainly a physical or biochemical underlying cause for it, which we can do something about. So I hope this learning module has raised your awareness on PTSD and made you think about it in your day-to-day practice. Don't forget to make an entry in your learning diary and possibly discuss it with your friends and colleagues at work. And good luck to those of you who are going to do 22 press-ups over the next 22 days. I'm sure you'll do a lot better than I did. And thanks very much for watching.
One for the Queen and one for the regiment.